Hello, everyone, and welcome to PTSD and Depression, What Caregivers Need to Know. My name is Lisa Meekum, and I'm a volunteer with Families for Depression Awareness, and I'll be moderating today's conversation. I'm a person with lived experience of depression, and I've been a caregiver for loved ones who have experienced depression and bipolar disorder. We are so glad to have you here with us, those joining live, and those of you who are watching the replay of the video later. I was going to tell you a little bit about how this is going to go. In a minute, I will introduce our expert panelists. We're thrilled to have a licensed mental health counselor and a neuroscientist to discuss how caregivers can better understand and support loved ones with PTSD. Just a note that throughout this talk, you'll hear us shorten post-traumatic stress disorder to PTSD. We encourage you to share your questions or comments in the chat throughout the discussion. We will weave in your questions when we can. And this program is being recorded and will be available to watch immediately after it airs. Finally, we'd like to remind you that we are doing a survey to evaluate our program. So if you can stick around after our presentation, please do and fill out the survey so we can improve our programs in the future. I would love to tell you a little bit about Families for Depression Awareness. Our mission is to help families recognize and cope with depression and bipolar disorder, to get people well and prevent suicides. Our philosophy is that when a person is living with depression or bipolar disorder, it's the people around them, it's the parents, the grandparents, the siblings, the friends, all of those people in their lives that have a strong and powerful position to support their loved one. Yet caregivers don't always know what to do, and that's where Families for Depression Awareness comes in. We provide education, training, and support specifically geared towards family caregivers so that they can be a strong advocate for their loved ones, they can be a partner in care, and most importantly, so that we can support family units, because that's what we really believe helps to improve mental health outcomes. The hub of our resources is our website, familyaware.org, which some of you may have already visited, but if you have not yet had the chance, please go to our website and you will see other webinars and workshops that we have had in the past and ones that are coming up in the future. The QR code here on this slide goes to our newsletter, which you can sign up for. And we encourage you to use our web tools, such as our depression and bipolar screening test and our caregiver stress test. We also have a mental health family tree tool on our website, and you can find loads of other resources, including family stories and expert interviews. So we encourage you to visit familyaware.org for more information and resources for family caregivers. Before we launch into our discussion, we want to thank our funder, Lundbeck, for supporting this program. And of course, people like you who donate. You believe in our mission, you believe in our cause. And if you are one of those people who have given us a financial contribution so that we can provide programming for free on issues of depression and bipolar disorder and how they affect families, we thank you. We greatly appreciate you. So now I would like to introduce our experts for our discussion. Leah Demarest is a licensed mental health counselor, certified alcohol and drug counselor, author, and public speaker. She is passionate about helping those living with mental illness and dispelling mental illness stigma. Dr. Jennifer Parazzini, a neuroscientist and entrepreneur, is founder and chief executive officer of Neurovation Labs. Dr. Parazzini's doctoral work forms the basis of Neurovation Labs' pioneering research, which made the groundbreaking discovery that there is a physiological component to post-traumatic stress disorder that can be targeted to both diagnose and treat the disorder. Dr. Parazzini and her team have developed a patent-pending detection method and are currently creating a companion treatment for PTSD. So welcome, Leah and Jennifer. So glad to have you here for this discussion. We're going to go ahead and alternate kind of back and forth for the first answer. And then, of course, the other one of you can jump in at any time. So Leah, why don't we start with you here? What are the most common signs of PTSD that caregivers should watch out for in their loved ones?
Yeah. Um, One of the main ones is anxiousness, hypervigilance. So if you find them, um, you know, being excessively worried about certain things, having panic attacks. So if they notice a smell or like a perfume of someone that maybe was an abuser or a car backfire that reminded them of like gunfire, and they start to have tunnel vision, shakiness, upset stomach, that would be a panic attack. Irritability or up and down mood changes, depressed mood. So just having that fatigue or um, just really feeling having the negative thinking patterns, memory issues. So if you're finding that they're forgetful of people's names, forgetting where they're putting their keys or um, different appointments or events, uh, and also having nightmares, flashbacks, things like that.
Thank you. Thank you very much. And Jennifer, how about you?
Yeah, I think I'm just going to echo what Leah had said. First, I'm going to answer basically every question from really a brain and behavior standpoint, since that's my expertise. I'm not a clinician, but Leah was very thorough. So just to reiterate, PTSD often shows up as a heightened reactivity to these stressful cues, sleep disruptions, avoiding trauma cues and reminders, and even changes in memory and attention. And so this may behaviorally look like hypervigilance, irritability, all the things that Leah had mentioned. And this is really all linked to how the brain's fear and memory systems really change after a trauma. So it's all physical in the brain.
Oh, that's really interesting. I think as someone who doesn't know much about this distinction, PTSD is one of those terms that's just sort of thrown around in the culture. So I think it's really helpful to understand the distinctions, which leads to our second question. And Jennifer, we'll start with you. How can you tell the difference between PTSD symptoms and symptoms of clinical depression?
Yeah, to me, the distinction lies partly in understanding the underlying neural circuits, the brain regions involved. So, PTSD in general centers on the fear centers of the brain, threat detection, even memory systems. So, these are brain regions like the amygdala and the hippocampus. Maybe you've heard of them or maybe you haven't, but they're little brain regions. Depression affects reward systems, mood regulation systems. So that's like the prefrontal cortex. However, that being said, there is so much overlap in the brain. And then in real life, symptoms can co occur or look similar. So, like that withdrawal we mentioned, the emotional numbness, loss of interest. So, it makes behavioral observation sort of difficult, a little bit tricky, I think, for a clear distinction. Depression can even be considered a symptom of PTSD. So that makes diagnosis by behavioral symptoms alone even more tricky. So for me, if you're a caregiver and you see any of these symptoms, whether you think it's PTSD or depression, or maybe both, because they can occur together, it's very critical to see a doctor or a psychologist because getting the right care and intervening early is always my mantra. So.
Well, thank you for that. And how about Leah, in your clinical practice, how are you seeing this and how do you differentiate?
Yeah. So with depression, there's the little interest. So not finding joy in things that we typically find joy in. So doing our hobbies less, spending less time with people and isolating, having a hard time sleeping or sleeping too much, being irritable. Um, PTSD has all those symptoms, and then in addition, the anxiety symptoms that come with that. So the panic attacks and the hypervigilance. So PTSD, um, like um, Jennifer said, depression is a symptom of PTSD. So that's the difference, is that just that depression doesn't have the anxiety symptoms and PTSD does.
That makes a lot of sense. And there's actually a question here from Ari saying, can one diagnose activate the other? If someone is deep in depression, could that make their PTSD worse?
Yeah. So because yeah, depression is a symptom of PTSD. If let's say you already have depression and then there's an event that causes that PTSD, that depression can go deeper, and so those symptoms of the depression can then be heightened.
Jennifer, how about, do you have any response to that from the neurological standpoint?
Yeah, so what we've studied in general is that chronic stressors, even if they're small, can make both PTSD and depression symptoms worse and more difficult to treat. So yes, I think the diagnosis of one can really hinge on the other.
That makes sense. Thank you for your question. And just a comment here that it must be tiring to live with PTSD, which I think it sounds like is definitely something the two of you are indicating is definitely a symptom and an experience of it. All right, we're going to move on here. This one's a two-part question. So, Leah, I'll give you the both, and then you can sort of address them both as you'd like to. How is trauma connected to PTSD and depression? What might caregivers observe related to their loved one's experience with trauma?
Okay. Um, well, trauma is the event, right? So it's like the car accident, the prolonged emotional abuse, where PTSD and depression, they're the mental illnesses that can develop after a traumatic event. Um, so with trauma, some of the symptoms can include like emotional numbness, flashbacks, nightmares, difficulty concentrating. Um, but with PTSD, you can have those, but those symptoms can include like hypervigilance, avoidance, changes in thinking and mood. The With the symptoms from trauma, they can last, a short period of time, like 2 weeks maybe after any event. So, a few days, a few weeks, let's say after a car accident that, it might be you might feel kind of goofy driving on a highway, right? And you're feeling kind of goofy or you're a little bit hyper vigilant. But then that kind of goes away after a few days, a few weeks. It would be considered PTSD if it was 3 months or longer that you're having these symptoms and that you're maybe shaking or having panic attacks whenever you're trying to drive. So, um, trauma symptoms are short lasting, where PTSD and then the depression symptoms can be chronic.
Okay, that makes a lot of sense. Jennifer, how about from your perspective?
Yeah, just to echo again what Leah said. So trauma is that biological stressor, right? And so what I study is a trauma really rewires and changes the brain, all those systems I had just mentioned, involving emotion and memory. So what's very interesting though is that not everybody exposed to a trauma they won't develop PTSD or depression, but those who do, their caregivers might notice really persistent and long-term changes, as Leah had mentioned, in mood, startle responses, attention, and caregivers may notice that their loved ones may react very, very strongly to specific cues related to the trauma, socially withdrawing, really seeming to be stuck in these negative emotional states that, again, last longer than just a few days. I think it takes 30 days to be diagnosed with PTSD. But I think it's very difficult to distinguish between PTSD and depression behaviorally. So it's important to see someone like Leah or, a psychologist or a therapist that because I keep reiterating this, but the symptoms are so similar and they could be co-occurring, depression and PTSD. So really just seeing any of these symptoms, it's so important to see a professional.
That makes a lot of sense. Thank you. And I think this next question, Jennifer, will get a little bit into that. If some of those symptoms are the same, and some of the experiences that caregivers may be seeing loved ones go through, what resources and professional support options are available for individuals with PTSD? And I guess, if the symptoms can be the same, I'm wondering if treatments are different that's just my own question, if there's different treatments for the two.
Yeah. So again, I can't provide clinical referrals, but support often involves therapies like cognitive behavioral therapy, exposure-based therapies. I think they're really great. I think they're a really important tool in the toolbox because, believe it or not, they can actually target the brain's adaptive responses to trauma. Additionally, pharmacological intervention is also an important option to consider. This is really what I work for and am doing in my company, Neurovation Labs. So right now, to your question, Lisa, there's only 2 approved medications for PTSD, and they're antidepressants. So in my mind, they're targeting that one symptom of PTSD, but maybe not necessarily all. But the good news is that many, many others, including mine, are being studied. And so it's important to make sure that as many symptoms are being treated and covered as possible. So a lot of trial and error is necessary right now, I think, with a good medical regimen. Either way, whatever path you choose, whether it's therapy or medication or a combination of both, it's very, very important to have patience, not just for yourself as a caregiver, but to your loved one who you're caring for. Again, this takes a lot of rewiring of the brain. So a successful treatment isn't going to happen overnight. I think that's important to remember.
Absolutely, especially if you're trial and erroring different things to try to target it. That makes a lot of sense. Leah, how about you? What do you see in your clinical experience?
Yeah, very similar. I, really, I think it takes a team. Some people, might just go see a psychiatrist, might just go to therapy. But I think it's good to, um, you know, try different things, have a team, see what's, the different types of ideas to help them. So going through therapy to do the processing, like Jennifer said, with the CBT type therapies, and then a psychiatrist can help with like the medication management. There's also group therapies. So spending time in group with people who have also gone through similar things, that connection can really help people process through things, knowing that they're not the only ones that maybe have gone through something like that. And NAMI, which is the National Alliance on Mental Illness, they, at least in my area, and I think it's countrywide, they have groups for caregivers, for peers, for people going through mental illness, struggles. They have different groups, support groups, and classes. And I just think NAMI is just a great resource for families as well, because you can get so much information and so much support there as well.
Thank you. Yes, that's a resource I've used many, many times. And like you said, um, there are NAMI groups all over the country, and from their website, which I believe is NAMI.org, and I'm sure that our staff will put it up here shortly, you can locate resources there. We have a couple questions I just want to get to here, and comments. A comment that, yes, recovery takes a long time. And I think that's something in all the talks we do here at Families for Depression Awareness as a caregiver, to have patience, to understand that the first thing might not work, that there could be some resistance, and that things just take time. And on the topic of resistance, a question: what is the best approach to support an individual who is resistant to care? So either one of you can handle this. Leah, if you want to start from a clinical perspective, if you're counseling a caregiver, someone who's dealing with someone who's resistant to a diagnosis or to getting help.
Yeah, that is very difficult, and it's very common. It's really being patient, and choosing words wisely, not trying to, choose words that don't say I'm going, make them do this, or you have to do this type of thing, because that type of language can often make someone more resistant and heighten moods and things like that. So making different suggestions passively, have you tried this? Do you think you could try that? Um, maybe giving them a card that you got, oh, I went to this conference or whatever. So doing things more passively, asking them, what do they feel like they might need, or let's work on a goal, like what's one goal that you feel like you want to accomplish, and let's work on that. And maybe it's just getting a job. Okay, well then what are the steps to that? But I think the main thing is being patient and making sure that your mood and your language is calm, because otherwise they're going to just come back at you more irritable.
And I imagine with, as you both have talked about, the anxiety aspect of PTSD, that affects the way that, you're feeling when you're in a PTSD state, and the way that you would like to be considered and talked to and have your, you know, state of mind held. And I think as caregivers, we always want to fix, we want to swoop in and have the answers, we want to make everything better. And that's not our job. Our job is just to allow everyone in our lives to have the dignity of their own experience, and to, as you said, Leah, provide them with resources and to listen and to help. But it's very, very hard. This is something that I've been a resistant patient myself, and it's very, very challenging. Jennifer, do you have anything else you wanted to add about that aspect of resistance?
Sure. Yeah, I think Leah is much better suited to answer the question from a clinical standpoint, but just something that I've observed from my previous work with veterans is that there are many of them that remain undiagnosed and untreated. And it's because they are resistant to care. And that's for many reasons. But one that I see that's very consistent is that there's such a stigma around PTSD and getting the diagnosis. And so to Leah's point, it's about patience, but I think destigmatizing, letting your loved one know that it's okay and this is a physical problem, it's not just in your head, I think could also help in some ways.
That's a really great point. I mean, all mental health is stigmatized, and that's really interesting, in particular to PTSD. Another comment on here, it seems to me that having a community of support would be helpful, spending time with people who are also navigating PTSD as person with PTSD or as a caregiver. So that speaks, Leah, to what some of the resources you talked about. Seeking group support is so helpful. You don't feel so alone. You don't feel so stigmatized. So that's a wonderful comment. And then a question about if EMDR helps with trauma. Is that something you see being used in regards to PTSD? Leah,
Yeah.
you can go ahead. Yeah.
Yeah, so EMDR is eye movement desensitization reprocessing. And I'm not certified in that, so I haven't really used that, but that is a one that works well that what I hear for trauma. And it activates different parts of the brain. So while you're talking, they have you do different activities, follow things with your eyes and things like that. And what they found, and I believe they found this therapy on accident a while ago, but that it activates different parts of the brain that tend to heal trauma. So Jennifer actually might be able to give more information on how that activates the brain.
Yeah, I'm actually not certified in it either. I've never studied it. I've always taken the pharmacological route to my studies. Anecdotally, I've heard some good stories, and then other stories that it may not have worked. And I think there's a lot of research that needs to go into it. But I think we keep harping on, patience, trial and error. I think that trying this in conjunction with other traditional methods is totally fine.
Yes, and I think what's important to note is that Families for Depression Awareness, of course, does not advocate any specific treatment. We're here just to offer lots of different options and always encourage patients and caregivers to do lots of research on their own with their doctors to find what works best for them. Let's see here, Jennifer. Or actually, I'm going to go to you, Leah. We got in such great discussion, I lost my place there. This is another two-parter. So Leah, what role can family members and caregivers play in supporting someone with PTSD? And what are some practical strategies that they can use? And this is sort of on that question that we had earlier about resistance, but what have you seen with caregivers that have come? And what are your recommendations for caregivers?
Yeah. Really just, learning about PTSD, learning about the person's diagnosis. The more information that we have helps us to know the why behind it, the symptoms. This is why this person is behaving in this way. And it can help us to learn how to help them as well. Also learning about your loved one's triggers. So what situations, sounds, smells, other stimuli that kind of triggers them to be anxious or to get irritable. So knowing what triggers them can help you to avoid and manage those types of symptoms. So being aware of those things, and then also uh, offering like practical help, like helping them with their household chores, running errands, going with them to their appointments. That can be very beneficial for people, especially when they're in their depressed state and there's that lack of motivation, fatigue going on. Some of that stuff isn't happening, or in their anxious state where they maybe can't get out to go to their appointments. Another, listening, and listening without judgment, without having to give an opinion or advice. Just listen, just being there. Sometimes that's all we need, is just somebody to hear us. We need someone to talk to, a sounding board of, this is how I feel. I don't know why I'm feeling this way, or this thing frustrated me today and I just need someone to hear me. So being able to be that person to listen without judgment or giving advice, and then overall just being patient.
That's wonderful. And Jennifer, before I go to you, Leah, you have a couple of books you were mentioning earlier, to me personally,
Yeah.
that you've written, and maybe it's a workbook or something. Could that be helpful for caregivers to read to know a little bit more about
Yeah.
PTSD?
The caregiver specific one, it's called Through the Fog. It's a guide to caring for loved ones with mental illness. And that also has a workbook correspondence with that. So there's a book in the workbook. And what that does, it just gives you, it's basically a guidebook of all the different things that can come up with any mental illness. It's just kind of a vague, like these are the types of things. Crisis situations, that has resources that you can go to. And then the workbook goes chapter by chapter, has different questions and situations that you can write down. And it basically, at the end of it, when you complete the workbook, you have a guide on how to specifically help your specific loved one. So
That's wonderful. Thank you. Thank you.
yeah.
Jennifer, I know, you're working with the brain, you're doing this pharmacological work, but any advice you have for caregivers about how they can take care of themselves, take care of their loved ones, anything you have to share?
Sure. Well, first, from a neuroscientist perspective, I do want to say that social connection is really protective in the brain. It helps buffer stress responses. There's a lot of fun preclinical studies on this. So that's a really important point if we, want to stay as scientific as possible. But again, what Leah said is what I would say as well. Consistency, patience, destigmatizing PTSD, non-judgmental listening can all really help regulate the nervous system and calm the brain. And then again, practical strategies, helping reduce those environmental stressors and the cues, respecting the personal boundaries, which I know might be hard. But again, patience is key. And just encouraging routine, I think, may help as well, that support calm and sleep, because that's one big symptom of PTSD is sleep disturbance.
Oh, that's really interesting. Well, along those lines, we actually have a question when you said the word personal boundaries that made me think of it. And it's assuming you have permission from your loved one living with PTSD. What are good ways to talk about it with relatives? Um, I guess sometimes we're not really sure how, if someone's like, "What's wrong with Lisa?" How do we talk about it? What's a way that we can explain what's going on while still respecting personal boundaries? Do either of you have any thoughts about that?
I think it really is a case by case situation, because it's what does that person feel comfortable sharing? And so if you do have permission, okay, well, I have permission to say what, what exactly do you want me to explain? And it might just be as simple as, they're struggling with uh, fatigue, and so it's causing them to be unmotivated, things like that. And so it could just be talking a little bit about the symptoms and not necessarily the diagnosis. But some people are open book and they don't care, which is awesome, because then that destigmatizes, because the more that we do talk about it, the more people learn. But I think it's a case by case, just what that person wants you to share.
Absolutely. Jennifer, do you have anything to add to that?
No, I completely agree. I think it also depends on your audience, and knowing what they know and what they understand. And it really is sort of this fine line between that and destigmatizing PTSD. I know one conversation that I've had in the past with soldiers and veterans is the distinction between PTS, so dropping the D, the disorder, and PTSD. And my argument to keep it as PTSD is that, a disorder doesn't mean something is, wrong with your head. It's a physical disorder, just like strep throat or something like that you go to a doctor and get a checkup. But again, it's a case by case basis on understanding your audience and person you're caring for.
To add to the stigma part of it, how I usually put it, like Jennifer says, we would go to the doctor if we had a heart condition, right? We have a cardiologist, and we might tell our employer, our friends, like, yeah, I'm going to the cardiologist and I have to take blood thinners or whatever. And we would tell people that. So why wouldn't we go to the doctor to help our brain? It's an organ, just like any other organ in our body that we do not feel worried about telling other people about. The only issue is people are worried about talking about it is because our brain affects our mood and our behavior. And so then people think, well, gosh, they're goofy or whatever. But it's not something that we can control. We can't control some aspects of, a lung disease, a lung illness or heart disease or whatever. So, this is similar. There's just things that we can't control, and sometimes we just need therapies and medications for that as well.
That's such a great point, Leah. Thank you. Absolutely true. I'm going to go back to a question that I missed that says, from what I've learned, it's really important to have a foundation of coping skills before doing trauma work. How can caregivers help loved ones use coping skills to manage PTSD? Leah, do you have any thoughts about that?
Yeah. So yeah, when you're going to therapy, even trauma work or anything, when you're talking about things that are triggering, it's going to heighten your symptoms. So even after therapy, you might feel extra anxious and things like that. It's just like if you're going to physical therapy for an injured muscle, that muscle is going to be sore because you're just working it out, right? And so that's similar to when we're going to therapy, we're talking about the trauma, we're talking about negative things. we're going to be reliving things, we're going to be feeling those emotions. And so being prepared by having those coping skills. So when I feel anxious, what are the things that I do when I feel anxious? And I need to make sure that I make time for that after my therapy sessions. Um, so sometimes with caregivers, what I say is, maybe we have a binder that we keep, and we have written down all these coping skills. So then it's a go-to thing when we see someone going through a certain experience, a trigger, and they're having a certain emotion. Oh, maybe I should suggest this coping skill, or the person with the mental illness. And when we're feeling like some of those emotions, when we are triggered, sometimes, we know our coping skills, but sometimes they just don't come to our brain in the moment. Having that binder or having something somewhere that I can just read it and I can pick something. But making that time after therapy to uh, do some sort of coping skills or self-care.
Oh, I love that idea. And it seems like a nice way for caregivers and their loved ones experiencing PTSD to just talk about it. Hey, when this happens, this is what I need. This is what I'm feeling. I love that idea and having a resource book around that. Jennifer, did you have anything to add to that?
Yeah, I guess just from a brain and behavior standpoint. So PTSD is really what happens when, after a trauma, when coping skills go awry, when these adaptive responses sort of go awry. And the way I like to think about healing is almost relearning these coping skills. So I think it's okay to not necessarily have that adaptive, response, that foundation it's perfect for you to heal. Because then it would be much easier, right? And we wouldn't have to have patience and tools in the toolbox. But I think that for the caregivers and the person you're caring for, it really is this learning of new coping skills where you're not necessarily erasing the trauma, but you're learning to sort of live with it. And that goes back to everything that Leah suggested. So
Oh, that's great. And here's a very specific question. What are some effective ways to de-escalate anger episodes related to PTSD? Leah, you want to start with that?
Yeah. Again, it's case by case, what calms a person, but um, you know, suggesting one for us, it's tone of voice, right? So caregivers, if we keep our tone of voice low, if we don't do the like blame game, pointing fingers, like you do this and you do that, whatever. So if someone's angry, about, oftentimes it's not something huge, and so we need to come at them in a calm tone of voice and just say, okay, I'm sorry, and apologize, in order just to let them calm down, and then come to them later and maybe talk about the issue, suggesting, okay, let's take a break from this conversation, or let's go take a walk. That can help. But then another thing to try, is, there's different somatic things, so physical things that we can do, like putting an ice pack or a warm pack on the back of our neck, uh, stretching, deep breathing, things like that. So if we do take a break from a conversation because we're getting irritable, going to our room or specific areas and doing some of those physical things too, that can kind of calm down that nervous system.
Oh, that makes a lot of sense. Jennifer, neurologically, do you have any feedback on that question?
I think Leah answered it perfectly. I think that makes complete sense, and she's much better suited to answer. But really, just highlighting what Leah said about, being able to calm the nervous system down physically, and that still calms our brains down, right? So I think that's a really important point, that it is still physical, and it's the body's all connected to the brain. So
Yes, here's another symptom. So again, understanding it would be case by case, but maybe just if you, Leah, have anything in general to say, what should I do if my loved one experiences flashbacks or nightmares?
Um, it at that point, when they're having, they just maybe had the flashback or the nightmare, I'm sure they're, you know, if they're having a flashback, sometimes they might be having like a panic attack or anxiety attack during that time. And that's where, you encourage them, okay, let's do some deep breathing. Let's do the physical things of ice pack on the back of the neck, warm pack, stretches, humming, singing, talking to vibrate up here. It hits what's called the vagus nerve. Um, Putting a ice cube at the roof of your mouth and pressing it to the roof of your mouth, and that's going to kind of calm you down to, you know, if you are having an anxiety or a panic attack because of those flashbacks and things. But in order to stop with the flashbacks, for them not to occur, that's something that just, therapy is going to help with. So doing some of that talk therapy and things like that is going to cause that to happen less often.
Jennifer, I'm really interested if from a neurological standpoint, why the body and the brain would bring back the revisiting of something like that. Is there a quick answer for that? From
No,
a brain standpoint?
so the fear center of the brain that I've mentioned earlier, the amygdala, really stores a lot of fear memories. And that area is very, very sensitized, somewhat permanently, with untreated PTSD. And when we have this hyperactive, this overactive amygdala, lots of the symptoms may occur, including flashbacks. So that's my short answer.
Yeah, no, it's fascinating. Well, thank you both. Another question. How can you explain to children the effects of PTSD of their loved ones so they do not have anger or resentment or confusion or fear? Leah, how do you help your patients deal with that?
Um, let's say it's their parent or whatever, they are sick, and so just like you might have a stomach ache and you get irritated when you're in pain, uh, they are sick in their brain and they get irritated sometimes too when their brain doesn't feel good.
I love that. Jennifer, I know you aren't in a clinical setting, but do you have anything to add to that?
No, I really think that's a great answer. And again, just really, if we can teach our children young to not stigmatize mental illness, maybe we can really change the way we think about treating them. So
Yes, and in my experience, if you don't talk about it, oftentimes children can come up with their own stories that are much more scary about what's happening versus just what's actually happening. So, and I know a lot of therapists will work with caregivers and the patients to help them come up with exactly the right language for their children to feel like they can understand what's going on. Let me see here. We have another question. What neurological changes occur during successful PTSD treatment? Um, Jennifer, do you want to start? Well, obviously the neurological, yes.
sure.
What you
Well,
see.
I began talking about this earlier, and of course, there are lots of different things that happen in the brain. It's sort of like a domino effect. When one thing happens, something different in a different region happens. Everything's all interconnected. But what I've studied is the amygdala, that fear center of the brain, and so we see it's always overactive with PTSD. What we hope to see with any treatment, whether it's therapy, medication combo, is that we sort of dampen down that signal back to baseline, back to normal functional levels. That's my short answer. Yeah.
Leah, do you have anything to add to that from what you see maybe with patients, and what does it look like when treatment's been, useful and helpful? And
Yeah, I mean, neurological, she kind of has that down. I agree with all that, but yeah, when treatment, we know that it has worked or is working, you notice less of that like almost immediate or impulsive irritability or feeling scared or hypervigilant. So you're noticing less intense symptoms. You're noticing that the symptoms are happening less often, and yeah, they're just not as big.
Makes sense. Is there any difference generally between PTSD in women and PTSD in men? Interesting question. Either one of you, Leah, have you experienced that from a clinical side?
Yeah. I feel like with PTSD in women, there is more of that, um, like hypervigilance that I see. Um, and I hate to generalize, I guess, because I do always think that everybody's different. Just we all react to things differently. But in general, I do see more like hypervigilance, and like the fear feeling, from women. Um, and then the men is more of the like isolation and like anger type stuff. But yeah.
Yeah, it's always hard to make these distinctions. Jennifer, how about from your side?
Yeah, well, first, I want to state that PTSD occurs almost double in women than it does in men. It's really important, I think, to study in both. And in my preclinical work, there are some differences between males and females. The animal work that we've done. There's more resistant to extinction treatment, so almost like exposure therapy in humans. And then there's some other small distinctions, really specific distinctions in the brain, but that's still really, we're just scratching the surface on those types of studies in the lab. So to be continued, more on that.
Yes, it's a mix of the cultural, the biological, the neurological, everything's at play. Well, let's see, we're winding down here. So I guess for both of you, if there's anything we haven't touched on or anything you want to reiterate about PTSD, about caregivers taking care of themselves, helping to take care of loved ones, anything you'd like to say here as we come to the end. Leah, you can go ahead and go first.
Really, I just encompassing, I think, in all mental health care, the destigmatization, learning more about it, talking more about it through things like this, so that we do have a better understanding, so that people aren't afraid to go get care, because oftentimes we don't get the care because we don't want people to know that we're doing that. And for caregivers, remembering your realm of control, right? Like, so there's only so much that we can control in regards to caring for a loved one with mental illness. We can, talk to them, give our advice, our opinions, but it's up to them to listen to us and take that advice and those opinions. And so we have to remember what we can and can't control, within, caring for that loved one, and then just making sure that we care for ourselves, doing that self-care for ourselves as well.
Thank you. Jennifer.
Yes. Brain changes after trauma are real, and they're physical, but they can also be recalibrated over time. So to me, recovery doesn't mean erasing the trauma, as I'd mentioned earlier. It means helping the brain really relearn these safety cues and calming down that fear sensitization, that overactive amygdala, right, that has occurred after the trauma. And I really just think caregivers are part of the learning process. They're an important learning cue, a safety cue. But of course, caregivers can't do it all. I think that's really important, is that, maybe it seems overwhelming, and I can only imagine, but just being present and supportive and informed and educated can really make a big difference in how the brain recalibrates over time. I'm always bringing it back to the brain because it really is, it's physical. So I think that's important to remember.
Thank you so much. I would just add a little anecdote I was thinking of here, how when I myself was going through a time of depression, and a friend said, I'm just going to come over and sit with you on the couch and hold your hand. And that did more for me than a lot. So I think it's such a good point. We can't change, we can't fix, we can understand, we can listen, we can encourage, we can um, be there in the way that our loved ones are asking us to be. And I really appreciate everything you guys brought today in terms of this discussion of PTSD and how it differs and is related to clinical depression. Very, very grateful to you. So, and thankful to all of you who came and watched live or watched this recording. We hope this information empowers you, your loved ones, and your family. If you would like to keep learning with us and all the things that we talked about today, and resources and other workshops and ways to learn more about all of these issues, please go to our website, familyaware.org, and sign up for our newsletter. You can follow the link here on the screen or scan the QR code to fill out our survey, which would be so helpful for us. Your feedback is really important so that we know what issues you would like to learn more about, and we can bring those to you. From all of us here at Families for Depression Awareness, thank you to Dr. Jennifer Perzini, to Leah Demarest, and to all of you for being here, and good evening.